Hi, everyone. Welcome to week 3 of Quality and Performance Management in Healthcare. This week, we're going to be talking about Problem Intervention Outcome Meta Model, which is a tool used to help plan a study surrounding a particular problem. And it is quite extensive and it can get a little bit complex, but we'll try and work through all the intricacies of it as we go through the lecture. Just another reminder for your weekly quizzes. Weekly quizzes are due on Friday. I try to release them on Monday so that you have the entire week to address them as you can. Other than that, if you're having any problems with the course or problems understanding course material, please reach out sooner rather than later. There's nothing worse than getting questions really close to a midterm and not having proper time to address them. So let's get all those questions out now while we can and get that solid foundation of learning. All right, so on to the material. So first things first, we're going to talk about the concept behind the problem intervention outcome meta model. So last week we talked a little bit about change itself and the mechanics of change and what goes on with that. It's really important to understand that modeling change is a complicated process. And this is due to the complexities that surround the issues of population well-being. So there's a lot of moving parts that go into what goes on with change. Now, health behavior change interventions, they initially target individual factors of behavioral change. So we're looking at increasing someone's knowledge or motivation behind making that change, or health-related skills towards that, such as proper, for example, hand hygiene techniques and along those lines. Behavioral and social interventions, which impact physiological functioning, are more likely to be more successful when applied in a combined level of influence, so across multiple settings. So if we just kind of lay out an intervention that tackles one setting, chances are when that person is not in that setting or interfacing with that setting, it won't be on top of mind. It might not create the proper foundation to kind of instigate that behavioral change. Whereas if we try to plan it across multiple levels of influence, there's a higher chance that we'll obtain some form of change in that individual. So what the problem intervention outcome meta model provides is a description of how a problem will change in relation to the implementation or introduction of an intervention within certain contextual factors. So for example, if I'm looking at something like infection control in long-term care, and I'm implementing a hand hygiene intervention. So what I'm doing is I might be putting up different material around that long-term care home to educate the staff in the home or give them that friendly reminder of, hey, practice proper hand hygiene. What I'm going to do is see how that problem of, let's say it's influenza season, how that influenza problem I might be experiencing in my long-term care facility, how that changes in relation to the implementation, or in this case, the distribution of educational materials on hand hygiene. So what it consists of, so the problem, so in the identified sample or population, there's 1+ health problems. In terms of intervention, these problems can be addressed through one or more interventions. And then the outcome, so the interventions are aimed to achieve a specific outcome. So in our case, our sample or our population, it's going to be the residents of the long-term care home. Now they have 1+ health problems, right? That might be influenza season, or there might be some sort of bacterial disease or infection that's spreading through the home. We can implement at least one intervention to tackle this problem. So in our case, it's something as simple as hanging up a poster right next to a sink, reminding staff to do hand hygiene. I might also introduce maybe monthly seminars as a form of intervention. It's still educational intervention, but more than one intervention can be applied. And that intervention is aimed at the specific outcome. So the outcome I can look at is I'm most likely going to look at the spread of the disease throughout the home. I might also look at knowledge of the facility staff regarding hand hygiene. So I can look at multiple outcomes. The outcomes, what we want to see is a positive change over time, right? So we're going to look from time 2. in this example, let's use something quantifiable. So let's say we're looking at the education of staff regarding hand hygiene. I might distribute a test before I put out the educational material. I'll collect their scores. That'll be their scores at P time 1. And then after I implement my intervention, I'll give them another test. Let's say it might be a month later, it might be 2 months later, and then those scores will be P time 2. So what I'm going to do is I'm basically just going to subtract time 1 scores from time 2 scores, and I'm really hoping for a positive number here. That positive number will tell me that their scores at time 2 were higher than at time 1. So in that case, I know that my outcome exhibited a positive change over time. All right, this can be kind of tailored to your circumstance. So if we were looking at like number of residents who are experiencing influenza at the time, we would actually want to see this number be negative, right? So it depends how you frame it and what you're looking at. On this slide, we're just looking at kind of a graphical, a visual representation of the PIOMM. And what we see there is we see the problem. So problem at time 1, problem at time 2, and it's all within the sphere of the population of interest. These are the people that we're looking to make that beneficial change to. All of this also resides inside of a setting. So the setting is important because depending where this all takes place is going to influence how I introduce my intervention, or it's going to influence how the intervention interplays with the population of interest, okay? So in this kind of sense, I would not do the same sort of intervention in a long-term care home as I would if I'm working with a group of community care nurses, right? In one setting, I can hang up posters within the facility close to hand hygiene or hand washing stations, whereas with community care nursing, where you're going out into someone else's home, I might have to rely on something like a video training, kind of instructional or something along that line, maybe a weekly newsletter that has something about hand hygiene, but the intervention is going to change is the point. What we do is we introduce or interject that intervention to the population of interest through the setting. And then we're going to measure over time what happens with the problem. Does the problem change? What happens, right? We might see that problem in long-term care go from influenza now to a different kind of issue that's no longer influenza, something that's not reliant on lack of hand hygiene. So now we're going to relate the PIOMM to something like the CDC logic model. So if you remember from a previous lecture, a logic model is basically just a graphical representation of a theory, and it's usually regarding either some form of program or an evaluation. Now, we can put these two things side by side. Now, neither one is either the right way or the wrong way to do things. It typically isn't what you favor, right? I tend to lean more on logic modeling than the PIOMM, but other people are the exact opposite of me. Essentially, the components within a logic model, it can contain inputs, which are just the resources that go into the program. It's going to include outputs, which is what's produced by the program itself. And then you're going to have short-term, intermediate, and long-term outcomes. All right, short-term outcomes, they're just the immediate effects that we can attribute to the program. The intermediate outcomes, they're typically changes in action, so behaviors, procedures, decisions, might be social policy, and long-term outcomes are changes that are expected to materialize as a result of the program as a whole. Now, the reason you want to distinguish this in a logic model is when you design your program, you don't want to design something or your intervention, you don't want to design something with no goal of what you want it to accomplish and then figure it out later. You want to have everything kind of mapped out as to what you want to try and put forth. One other thing that I should mention here is logic models do come in all shapes, forms, and sizes. So if you look at this logic model and you think this is really confusing, I don't like the layout of this, it might be something as simple as I don't like the look of it. There are different forms of logic modeling, so I would emphasize just kind of taking a scan of the environment of what kind of other types of logic models are out there to see if it would suit your program or evaluation needs. Now, basically what this table is showing is where we would find the different PIOMM concepts within that logic model. So the problem itself, we can see it across the inputs, activities, and then the outputs, right? We would have to make some inferences. In other logic models, it might say it right at the top of the logic model. The population context itself, so we're going to see this once again in inputs, activities, and outputs. And again, we have to kind of piece everything together to get what that population context is. Inputs is going to tell us who's involved, their characteristics. It's going to describe the population overall. Activities is going to be telling us what they're doing. And then the population context itself, again, it kind of relates to the inputs in the sense of it's going to build that overall picture of who that population is. In terms of the intervention itself, so the inputs are going to tell us what kind of resources and costs we have at our fingertips. What are we putting into the intervention with the hope of getting out our anticipated outputs? The activities, so this is the actual intervention itself, what we want to do to tackle that problem. And then the output, basically, it's what's coming from our resources and our costs. So we can really look at kind of the cost benefit analysis using inputs and outputs, as well as our outcome measures, right? So we're tracking those resources, costs, and tasks, and we're seeing what they materialize into. What we're also going to see is we're going to see what kind of qualifications, training, and credentials are needed in the realm of the interventionists. So whoever is implementing that intervention. Now, if we go back to our long-term care facility example with that hand hygiene, I don't want to have my interventionist someone who knows nothing about hand hygiene. They might be putting information in there that's not necessary. That can actually affect the intervention itself by doing something as simple as cluttering a poster and making it not as effective as it could be. You want someone who has the proper qualifications, credentials, and trainings. The outcomes, you're going to find these at the right-hand side of the chart right underneath outcome measures. So these are our short-term, intermediate, and long-term outcomes. And pretty self-explanatory. It tells us kind of right there in the box. As for the time, this is something that sometimes will be apparent, sometimes won't, but it's going to be associated with the short-term, intermediate, and long-term. It's going to tell us kind of when we can expect to start seeing outputs arise, right? So typically short-term, I've seen it's things we want to see immediate, but within 3 months. Intermediate can be anywhere from 3 months to 6 months up to I've seen as far as a year, and then long-term typically that year plus. Now this is just the same sort of thing except relating the PIOMM with the IHI quality improvement model crosswalk. So again, we're just kind of comparing the two and seeing where we can find what we need in terms of the PIOMM model. So if you essentially what you can do is if you can use these concepts within the PIOMM, we can then transfer it across over to a logic model or this quality improvement model crosswalk. The idea here is sometimes, let's say I prefer the PIOMM, but my stakeholder prefers the logic model, the CDC logic model. I can now kind of easily transition between the two. Okay, so it's not necessarily something that you should have memorized in the back of your head. However, you should just understand that these things are relatable and can be transferred from one format to the other. All right, so now let's talk about using the PIOMM. So basically what it does is it provides a robust meta model for planning a real-world study, enabling identification of key data and resource needs for completing a successful study. So when you're going into planning a study, you have to understand the problem at hand very thoroughly. You have to understand the population that's experiencing the problem, and you also have to understand the resources and data types that are at your fingertips. Without this kind of knowledge, you're basically shooting in the dark, and realistically, it's not really efficient in terms of time and resources. So I've seen this happen in my own professional experience, where you go to roll out a study, or you plan the study and you go to roll out, and then you realize you've missed a really important either key indicator, or you didn't understand the population at hand. So when you go to implement your intervention, it doesn't really, for lack of a better way to put it, it doesn't really gel with the population at hand. And at that sense, you're just setting yourself up for failure. So again, for those of you who took program planning and evaluation, you've heard me drone on about this over and over. You have to understand basically everything that's going on into your population, your intervention, that program or intervention that you're planning, in order to have success with it. Probably the most important thing we have to keep in mind is that when we are designing an intervention in a study, it has to be bounded within the setting in which the intervention and population come together. So if I go to plan my study, and using the long-term care example, I should say, if I plan my study and I want to see what hand hygiene practices are like maybe in the staff's home in their everyday life, well, that's not going to tell me anything about the intervention itself, because it doesn't mean that that intervention or that those scores will translate into the setting that I need them to translate into, right? If I look at it just from a general viewpoint, someone at home might have more time, they might be more relaxed to perform hand hygiene properly, whereas in a long-term care facility, maybe they don't have that time, they feel rushed, and so they're taking shortcuts and not performing hand hygiene. At that point, I would know I need to tailor my intervention a little bit different to make those staff understand that hand hygiene should be placed in priority, and there's no sense rushing to the next resident without washing your hands first, right? That's an educational point that I need to focus in on. The model also ensures that you engage with stakeholders in order to build trust, acceptability, and value within the study. So the best way to look at it is you will become an expert in methodology, right? Everything you've learned to this point should be things about performing the study, ways to collect data, so on and so forth, whereas the stakeholders live in this realm day in and day out, right? I am not necessarily an expert in the application of medical services, right? In my long-term care example, that's what the nurses are for. Now, I might not go directly to, let's say, a frontline nurse and start asking them questions about the study. I might go to their managers, but I'm still engaging with some form of stakeholder to ensure that as I build my study, it makes sense, right? Now, there are a couple statements that you will generate based on the PIO-MM. So the first is a statement of the gap in knowledge. So basically, we don't know if the intervention addressing the problem is effective or efficacious for the given population in the specific environment. That's just a given. If I knew that it worked already, I wouldn't need the study to tell me that. The state of purpose, so we're basically stating the purpose is to examine the outcome of the problem after the intervention in the setting and population is put out, right? So I'm basically stating I want to look at how hand hygiene knowledge and skill and compliance improve after I roll it out in the long-term care setting amongst frontline nurses and PSWs. The project hypothesis, so we're hypothesizing that the interventions are associated with changes in the problem for the population we've identified in the described setting over the given time frame. So I'm going to outline in this kind of what I expect to see, which we expect to see changes in the problem themselves. I'm expecting to see hand hygiene skill go up, same with knowledge, in my identified population, so my frontline nurses and PSWs, in the described setting, so the long-term care facility, and then over a given time frame. So this one, it's mostly going to be informed by the literature or the constraints that are available on your problem. Sometimes it can be something that's come down from the Ministry of Health, and in that kind of time frame, for example, if you get orders because your facility is non-compliant, you might have a 3-month time frame before you can improve scores, and the inspector is coming back. So my time frame might be dependent on that. My project question is typically going to follow the format of, are interventions associated with changes in the problem for the identified population in described setting over a given time frame. So you can see that the project question and project hypothesis, they're linked together, right? So in this case, are my hand hygiene interventions, in this case maybe posters, associated with changes in hand hygiene knowledge and compliance for frontline nurses and PSWs in long-term care over a 3-month time frame? And then the last one is we're going to set out project goals. So we want project goals to follow kind of the SMART guidelines. So we want those goals to be specific, measurable, achievable, relevant, and time framed. So I might say for myself, a specific goal will be that increase in hand hygiene knowledge and compliance. This can be measurable because what I can do is I'm going to actually put out a test, as well as I can put out audits in the same time to see how compliant the staff in my facility are. Achievable, so this is where I'm going to set a standard that I'm going to consider a success for the intervention. You may have standards that are set for you, or it's going to be something that you yourself can implement. So for me, I might say that I'm looking to see, a 20% increase in scores over a 3-month time frame, as well as I want to see my compliance meet the goals laid out for me by the Ministry of Health. All right, so I have one goal that I've come up with myself and one goal that has been given to me. Relevant, well, my overall problem, I'm looking at infection control practices, hand hygiene is directly relevant, and those scores that I'm collecting and the audits that I'm collecting, they will give me exactly what I'm looking for. They're giving me the idea of whether my hand hygiene intervention is working. Time frame goals, well, we've tackled this with the question and the hypothesis. I'm looking over a specific time frame, and for me that would be that 3-month time frame. Okay, so before we move any further, we're going to just review a couple terms that you should already be familiar with. If not to worry, that's exactly why we're reviewing them. Essentially, these are just going to be important as you either plan and design a study or you go through trying to determine your data analysis. So the first thing we're going to talk about is a categorical variable. Categorical variables have kind of a limited set number of responses, right? So this is something that, if you roll out a study, it's something that you can have kind of a multiple choice answer to return. So for example, I can ask in my survey, what is your hair color? Actually, better than that would be, what is your eye color, right? And then what we would have is we can have our answers of brown, blue, green, hazel, so on and so forth, but they're very discrete and they're limited, right? A continuous variable, on the other hand, is something that you're not going to necessarily have set boxes or buckets that you can put the answers into. However, it can be a range of things. So for example, if I ask you what your age is, right, I can have respondents that technically their age can be 0 years of age all the way up to 100 or more, right? So I'm not going to have necessarily 100 buckets in my questionnaire that someone can tick off. Next up, we have dependent variable. So the dependent variable is just a variable that relies on something else in regards to its change. Okay? Independent variable is the variable we are introducing or the variable we are manipulating to see the change of the dependent variable in relation. So let me try to explain this with an example. If I'm looking at let's say the association between physical activity and anxiety. What I want to know is, how does someone's physical activity level affect their level of anxiety? In this case, anxiety would be the dependent variable because anxiety would be relying on physical activity levels for its level of change. Physical activity would be my independent variable because that's the one I'm manipulating. It's not relying on anything else other than my own manipulation or realistically what's being reported by the participant, right? I might not change someone's physical activity level, but I might, in a cross-sectional study, look at the differing physical activity levels and seeing how anxiety changes in relation to that level. The next thing we have is a benchmark or a standard. This is basically just a level that we set It's basically the bar that we have to achieve, right? For example, and it can be either we want to be above the benchmark or below the benchmark. So, for example, I might have for, let's say, for children, if I'm doing a study on birth weight, I'm going to have a standard that I want children to be over that benchmark to consider them as a healthy weight. At the same time, if I go to the kind of the other end of life and I look at long-term care, I might have a benchmark for number of falls that I can achieve, and I want to be under that benchmark or that standard. The next I have is effect size. So effect size is basically an indice that describes the size and magnitude of difference between the means. Okay, so next up we have p-value. The p-value is the probability of obtaining a result at least as extreme as observed. So essentially, what is left up to chance, right? What are the chances that this happened randomly? Typically, we see p-values of 0.05 or 5% as acceptable probability of chance. We then have standard deviation. So standard deviation is just the measure of the spread of the data around the mean value in data that's normally distributed. So think about that bell curve, right? So in that bell curve, right in the middle, we have the mean, and then we'll have standard deviations separating kind of the ranges of normal dispersion away from the mean. Next, we have standard error of the mean. So it's a measure of spread of sample means from repeated samples of the population. And then last up, we have correlation. So correlation is basically just the relationship that two variables may have together. So it can be positive, where if one variable increases, the other one increases as well, or it can be negative, where if one variable increases, the other one decreases. Okay. I just realized two that I did miss. So confidence interval, basically it's the interval surrounding kind of our main finding. It's our confidence that if we repeated the experiment, the value we would get would be within that range, okay? Typically we use it as like a 95% confidence interval, which means that 95% of the time, if we repeat this experiment, that value will land in between our confidence interval. Let me give you an example. Let's say I'm doing an experiment where I'm measuring 100-meter dash times for, let's say, high school students, all right? Now, I am not a sprinter, so if this is a very fast time, it's just off the top of my head. If I get a mean value for sprint time of 100 high school sprinters, and it's 12 seconds, right? I might have a 95% confidence interval of 10 seconds to 14 seconds. All that's saying is that if I repeat this experiment, let's say 100 times, 95 times, that experiment will give me a value between 10 and 14 for the mean, okay? Now that's a very simplified way to put it. Typically we see this with things like odds ratios or relative risk. But yeah, the last one is the mean. We all know what mean is. Mean is the average. If you don't know how to calculate that, please reach out and we can get that sorted out really quick. If any of these terms are confusing to you, maybe I didn't explain it as thoroughly as I think I did, please reach out, because these are terms that you're going to want to understand as we move forward. All right, so let's talk about operationalizing the PIO-MM. So right off the bat, the first thing you have to do is identify at least one or more variables that can adequately measure the problem at hand. So if we go back to our long-term care facility example, we have two variables that we're going to look at. We're going to look at test scores, which measure the knowledge of the staff, and we're going to look at audit scores, which are measuring the compliance of the staff to fulfill hand hygiene obligations. Now, it should be known that these kind of measures are not always easy to identify. Sometimes it's really difficult to find the measure that you want. However, sometimes what you're going to have to rely on is something called the streetlight effect. So the streetlight effect is basically the measures you select are based on their availability, right? So I can't pick a measure like number of microbes on the hands of staff after or upon entering a new residence room. The reason for that is I don't have the equipment, the time, or the resources to collect that kind of data. My measures are based on their availability. Now, another thing is change theories, which are theories that explain why the change happens. They're complementary to the PIO-MM. Change theory variables would have to be identified in addition to these variables that we were talking about. So you're going to have kind of multiple sets of variables as you approach your study design. Okay, so you might have heard about PCOT. PCOT is something that is used a lot in research. So basically, it stands for population, intervention, comparison, outcome, and time. It's similar to the PIO-MM in terms of it helps you plan studies, it helps you plan interventions. However, they are different. The big difference here is that PCOT requires a comparison group or a control group. So it kind of expands on kind of the time dependency of PIO-MM of before versus after design, right? So what that means is with PCOT, while I need a comparison group, I can run two groups at the same time to test the intervention. With PIO-MM, I don't have that, so I'm going to kind of take my values. I'm going to use the people I have in my study as kind of both control and intervention groups, but the difference here is going to be time, right? So I'm going to look at before the intervention, right? That would be kind of quote unquote my control, and then after the intervention. And this is kind of what yields benefits when there's no control available. And there are times when there's no control available. It could be mostly resources. It could just be the availability of participants. All right, so now let's shift our focus to the design of PIO-MM. It's now at this point in kind of the design process where it's going to go from kind of two different branches where it's quality improvement and research as the different branches, and they're going to come into one. So this is where kind of those terms we reviewed before, you might have heard of them in kind of a research methods class. Now we're going to go back into the realm of research methods and use that to design our study. So intervention effectiveness work can be classified as observational studies. So observational study designs, they're used to describe characteristics of a population, typically outcomes, in response to an intervention by basically observing the sample without modification of the intervention. All right, so I'm not changing the intervention while the study is ongoing. So what this does is this study is going to describe the relationship between two variables to better understand the association between the two, right? Think about what I said about the physical activity and anxiety, right? I'm going to observe a group of people. I'm going to look at the anxiety levels that occur in those with high physical activity. I'm going to look at the anxiety levels that occur in the people with low physical activity levels, and I'm going to try and understand the relationship between the two, all right? In the quality improvement application, a single group is going to receive the intervention while observations are made, and then we're going to analyze to determine if the association between the intervention and outcome of interest occurred and is exactly what we want. So in this case, I'm going to introduce the intervention, which may be, educational material in one way, shape, or form, and I'm going to see what happens with the test scores and with the audit compliance scores. Observational designs introduce an element of realism that might be absent in experimental studies. In experimental studies, we are basically eliminating any sort of confounder, so anything that can mask results. We're also eliminating kind of the real world applicability to it, okay? So, and this was one issue that happened in randomized controlled trials in terms of medication, right? When someone was under study, and they were in, let's say, the intervention group, and they were receiving pills for something, they were very compliant with taking their pills because they were part of the study. However, as soon as that randomized controlled trial deemed that drug was good, it did what it wanted to do, as soon as they got into real life, all of a sudden it looked like the drug wasn't doing what it was supposed to. Now, it wasn't that the drug got any less effective, it was that the drug, people weren't very compliant in taking it. This is something we can see if, like, for example, you have to take 6 pills in a day. You're going to not really get much compliance. There's less realism in regard to that kind of randomized controlled trial, all right? So there is a bit of a downfall in terms of experimental studies where observational studies can kind of come in and deal with those issues. So as I was getting at, experimental studies and observational studies should not be seen as mutually exclusive. They are complementary to each other. So experimental studies are going to show the minimum level of benefit of an intervention, while observational studies are going to show the maximum level. So again, looking at kind of that drug example, the minimum benefit that you're going to get is just taking that drug as is, right? In terms of the observational side of things, that's going to tell us if the intervention is actually very beneficial, because you're going to get compliance rates and really see the real world applicability of it. So the first type of study design that we're going to look at retrospective study designs. What retrospective studies do is they look back in time from the point of the start of the study. Okay, so this is something where you're being asked of, can you rate your anxiety in the last 7 days, right? You're looking back in time at a specific variable. Now, the advantages of retrospective studies, so they're very good at describing associations. So this is typically seen in cross-sectional studies. Cross-sectional studies, they're essentially the first step towards further study and understanding the association. What we're going to do is we're going to determine if there is even a foundation for the association to exist, and then we're going to move on to a different type of study to A, confirm that association, and B, look deeper into the correlation and possibly causation within the two variables. Retrospective studies also enable comparisons. So we see this in case control studies. Okay, so it compares individuals who have exposure or characteristic of interest versus those without it. So for example, where I've seen this be really beneficial is in the cases of foodborne illness outbreaks. Okay, so more of kind of an epidemiological side, but it gets the point across. So let's say the local church put on a potluck dinner, and all of a sudden we have numerous cases of salmonella go on. What I'm going to do is I'm going to interview people, both people who had salmonella and people who didn't, and I'm going to try and find who the cases are and then who the controls are, right? So people who had salmonella, people who didn't have salmonella. What I can do from there is I can work my way backwards, because remember, this is a retrospective study, the events have already gone on, and I can see what they were exposed to in terms of food, right? Maybe what I find is that the cases mostly ate tuna salad, and in the control group, they didn't eat tuna salad at the potluck dinner. Now, in a real world setting, you're going to have some who have had the exposure in the control group. So in this case, people who have eaten tuna salad who didn't get salmonella or food poisoning. And I'm going to have people that are in the case group who might not have had that specific exposure, right? It might have been like a secondary contraction of the bacterial infection, right? So what we're looking at here when we look at case control is the probability that someone is going to become a case after exposure to a particular characteristic or event or pathogen. The other advantage of a retrospective study is changes over time, so in cohort studies. Now, it's important to understand that typically cohort studies are prospective studies. However, they can be done retrospectively through the use of large databases. So it's kind of done in the sense of secondary use data. So basically someone else has done a cohort study, you look back at their data, and you try and see what other associations you can point out. Maybe you have a different association of interest that you want to look at. You have two variables that they collected that you just want to see what's going on with. Okay, so next up we're going to talk about prospective designs. So prospective study design, basically you're going to recruit participants, and then you're going to study those recruits and follow them forward in time. Okay, so at this point you're going to essentially record the experiences of that person as they themselves experience it. The benefit of this kind of study design is that it's more valid than that of retrospective designs, due to, with retrospective designs, there's an introduction of a lot of bias, right? We have things like recall bias, social desirability bias that can impact how people report findings. Whereas with a prospective study design, you can either view it yourself as the researcher, or you can eliminate, I shouldn't say eliminate, you can reduce the recall bias because it's happened in the near past. Now, the downside of these kind of studies is it does cost more in terms of time and resources, right? So I can ask someone to recall the last 5 years, and we can go through that recall in the span of an hour. If I'm doing a prospective study, I actually have to stay with that group of participants for a full 5 years. Now, there are advantages of prospective studies. So the first, I can describe associations. So we talked about cross-sectional studies in the retrospective design. I can run a cross-sectional study in the same way, just moving forward. Now, we also have case control. These are typically retrospective because I don't know that something's going to develop in terms of case control, right? Like I can know that the church potluck is scheduled for Saturday evening, but I don't know that there's going to be a food outbreak. And so it can be costly in terms of time and resources if I think, oh, you know what, just in case there's a food outbreak, I'm going to run this case control. That's typically not how things are run. And so what we do is we typically run case controls retrospectively, right? It's typically in response to a rare disease or a rare occurrence that happens. And then we have our changes over time, so our cohort groups, which are a large group that's recruited and followed over time, and it determines if the particular exposure or characteristic leads to an outcome. Now, this gets us a lot closer to kind of our causal ability. We're still looking at association, but it's stronger than a cross-sectional study, right? We can kind of account for different things that go on. Realistically, what we need for causal determination is something like a randomized control study. However, a cohort is kind of the next best thing. Okay, so now when we talk about PIOMM and the research design, I thought this quote sums it up pretty good. And it says that PIOMM depicts the measurement of a problem over time in which an intervention occurs within the context of a population setting. At its simplest, it is a single group before and after design. Okay, and we've already touched on these factors on previous slides. Basically what it's doing is it's just looking at a group over time and we're introducing that intervention. Now, studying a single group before and after design, it has benefits, but it also has challenges associated with it. Okay, so one of the big benefits of these kind of studies are that participants are their own control group, so to speak, right? So they form the group that in theory is not getting an intervention. We're seeing, like in terms of the hand hygiene study, we're seeing what their scores are on both knowledge and compliance before any intervention has been interfaced with. Then I can give them the intervention, and now they become kind of the case side of study design, right? They've had the intervention and we can measure the same variables. And what it's going to do is, in essence, it's going to eliminate a large amount of confounding variables unless they picked up new habits or hobbies in the midst of receiving the intervention. Now, one of the challenges is it's not void of threats to internal validity. Okay, so there can be an introduction of bias into participants and the results, as well as the influence of external and uncontrollable factors, right? So for example, in the hand hygiene kind of example, if staff know that they're going to be tested before I initially put out the test and I'm looking at seeing, okay, what are your scores? Staff might, before their work shift, go watch YouTube videos on hand hygiene or study up on it. This is going to bias my results, right? It's going to look like my intervention either isn't necessary because they've got good hand hygiene knowledge, or it's going to make it look like it didn't work that well, right? These kind of external factors, we can't control for them. We just have to be aware that this is a possibility. There are threats to internal validity that are common amongst kind of any sort of setting. What we'll do is we'll work through some of these common threats that you should be aware of. I'll show you how it kind of applies to our long-term care facility example, but just be aware that it can manifest in a number of ways. Okay, so for example, one of the big ones is history. So when one or more events unrelated to the intervention occur during the measurement period, that could affect the outcome in some way or shape. Okay, so this could be in terms of kind of the hand hygiene experiment we're talking about. Particular participants, they get in trouble from their superior because it was witnessed that they're not washing their hands before they're entering the next resident's room. All right, what this will do is it will cause a momentary increase in compliance. So it's going to influence the audit scores, and it has nothing to do with the intervention, right? It has nothing to do with posters put up or extra educational material, but because they've been yelled at by a superior, they're going to wash their hands a little bit more to make sure they don't get in trouble again. There's then regression to the mean. So this is when the outcome may be due to chance or a proportion of the outcome may be due to chance. So in our example, this could be something to do with the test scores, right? I'm sure a number of you can relate to getting questions on a test that you have no idea what the answer is, and so you just guess, right? This can happen, right? On my test scores, I might just have a bunch of participants that are very lucky. They score very highly, but this is due to chance. The next we have is maturation. So group changes due to physiological growth or maturity, and it affects the outcome positive or negatively. Now, this doesn't really have so much to do with, let's say, our example here, but it does in other different kind of contexts, right? So this can be a huge problem when talking about something like youth sports, right? If I run kind of performance measurement tests on a team, a youth team in particular, at the beginning of a season, and then I run it at the end of the season, well, in between those two times, those athletes, they're going to mature, they can grow depending on kind of the age group of athlete. That can have an effect, both positive or negatively, on their performance scores. The next thing we have is dropout. So that's when some participants drop out or are forced to withdraw from the study during the data collection phase. So this may affect the generalizability of the findings, and then therefore you have to take this into account when analyzing that final data set and generating your kind of reports and recommendations. So in the case of kind of the hand hygiene example, so if I don't, let's take a circumstance where I don't do my due diligence and I'm not talking to the shareholder, the stakeholder, I should say. Now, because I don't have that communication, as I go to kind of implement my intervention, what can happen is someone much higher up in the organizational chart than me can say, you know what, this is unacceptable. Let's do mass firing, right? People aren't performing their jobs. So all the nurses that I initially had tested and PSWs that I initially tested, they have been fired. Whether I've put out the educational intervention or not, they've been fired. A new group of nurses comes in, right? This won't always be the case where you get a new group of participants, but I either will get a new group that comes in that is uneducated with the intervention, so that could influence my results to show that there is no change, or I could be left with just the group that did well on their initial tests, right? More than likely it's going to be that than the other. And so it could look like my intervention was more effective than it actually is. There are a few ways that we can enhance before and after design using comparisons. So we can enhance through the use of 2 or more groups. All right, so this can really diminish those threats to internal validity by collecting 2 or more groups. In long-term care facility example, maybe I take groups based on floors in the home. Also, comparison groups strengthen the study in that they allow for the true effects of the intervention to be known. So really the best thing I can do is I can take 2 groups and I can actually do a case control. I can put educational material on just one floor and roll out a seminar on that same floor. I can put posters on another floor with no seminar, and then I can put a seminar on one floor, and then on another I can put nothing. Now, this lets me look at exactly what the outcome of each intervention piece and the combination of the 2 are when I compare it to a group that got nothing, okay? However, just remember that even with these comparison groups, you still can't draw a causal inference. The reason for that is that we're not accounting for any sort of other kind of variable that comes in, right? So for example, as I roll out my study, the participants can go home and actually start studying hand hygiene on their own, right? I'll still potentially get the outcome that I want. However, at the end of the day, I can't say that improved scores on knowledge of hand hygiene and compliance on with hand hygiene is due to the interventions I put in place. It's due to something else that I had nothing to do with. So just always remember that we can't draw causal inferences. Okay, so on this slide, we're going to look at using PIOM variables and how we can use them to create different groups for comparisons, okay? So the first one is we can use the problem itself. So if there's more than one problem, we can stratify by problem and then compare the results. So for example, if I use the long-term care example, let's say my problems going on in a long-term care home are levels of influenza and levels of E. coli, right? Influenza being respiratory, it might be harder to gauge the effectiveness of hand hygiene compared to something like E. coli, right? So I can put in the same intervention and see how the levels change to notice, okay, was the intervention good for tackling what problem, right? Then I can look at making comparison groups by intervention itself. And so there's many different ways that we can group data for comparison, right? With my intervention, I said, okay, I'm going to put in posters, but I'm also going to hold education seminars or workshops. What I can do is I can stratify by what intervention the participants receive. They either receive no intervention, they may receive just the educational session, but there's going to be no posters on their unit. They might not get the educational session, but there's posters on their unit, and then they could have both, right? And that's done by intervention type, right? I could also just simply say, okay, I'm going to have a case control where one group gets all intervention and one group gets none, right? That would be something like binary, where it's either yes, they got it, or no, they didn't. Next is I can group by interventionist. So if my intervention relies on some form of medium to be implemented, so in this case, I could have different poster designs and then compare by that based on what floor each poster sits on. I can also look at, for example, with education sessions, if I put out an education session across 4 units and I have a different person putting on that education session, that might lead me to know, okay, does the educator of that session matter, or is the content strong enough, right? A lot of the times the educator is going to matter, but by comparing in that way, I can look at the scores, right? The knowledge scores, and see, okay, what's the difference between the sessions? Is it attributable by the interventionist? Next, we can group by outcome, right? And then so by having more than one outcome, i.e. Knowledge or compliance in this case, I actually make my result more valid, right? Or I should say I make the intervention more valid the more outcomes kind of agree with one another, right? Ideally, I want my intervention to increase both the scores on education and knowledge based around hand hygiene, but I also want it to increase the scores of compliance, right? That's an ideal world. If I can increase the education scores, but I don't increase the compliance, I know I haven't exactly reached my problem. I'm doing something right because now the education is there, but I'm still not getting the compliance I need, right? So the intervention is only half getting me there. I need to figure out what else to do, right? I can only see that by grouping or making different groups based on the outcome measured. So another way that I might create my different groups would be by population. And what I mean by that is by the individual characteristics, right? The demographics or baseline assessments. Now, in this particular case, what I might do is I might take my group of staff and separate it into frontline nurses and PSWs. And the reason for doing something like this may just be because of educational background, right? Nurses have a different educational background than PSWs, and so I may require different interventions based on those groups. But unless I run kind of that comparison group throughout my study, I really won't have an answer to that. So I'm going to separate by that kind of characteristic and see what materializes. Another way I can create comparison groups is by setting, right? So it can be by geographic location, it can be by health system, clinic, it can be by unit within the long-term care facility, and this can speak to just kind of resources available, workplace culture, so on and so forth, right? There are differences in setting that we should compare to see kind of if our intervention is generalizable. The next one is time. So we can compare by length of stay or duration of treatment, as well as long or short-term effects that can be used to stratify comparators. So it's very beneficial to chart the changes over time, as it's a good way to illustrate effectiveness. So this one, we can't exactly stratify by time in this setting. Now, if we said something like, we're going to put in an intervention for 3 months on one floor and then 6 months on another floor, or just have 2 interventions running at different time lengths, then we could kind of stratify by time, right? If we're looking at patient groups or like residents, we can do length of stay or duration of treatment. Maybe they're receiving a treatment, someone receives, I don't know, 3 months of chemo, another person receives 6 months of chemo, and then we can stratify by their duration of treatment to see what kind of the effect of the intervention has on people with those experiences. I do know that there's a lot going on when we're looking at comparison groups and the intervention in play. These kind of topics, there is a lot to them when it comes to study design, and it can get difficult to really portray all the differences. The easiest way to go about it is having kind of that working structure, that PIO-MM kind of worksheet or foundation, or whether you use logic modeling or just something to kind of organize your thoughts, and then letting your creativity kind of run wild, right? You still need that foundation of understanding what variables to collect and whatnot. That's what the PIO-MM is going to afford you. And then your creativity can come into, okay, how can we separate the groups? How can we measure things? What interventions do we want to have in play? They are very kind of context and situation dependent. Easiest way to kind of try and get a good grasp of them is to practice a lot, right? And so that can be at, like, for example, looking at something that comes up in the news, and even though you might not have intimate knowledge of, say, something going on in like a healthcare setting, you can still try to formulate, okay, well, how would I measure it? How would I try to figure this out if they were coming to me with this problem? So just to make it really simplified, if you look at something that says, you know, I don't know, Unity Health Hospital going through COVID-19 outbreak, right? You can even formulate a fictitious reason for it and say, okay, maybe they're not using PPE properly. What intervention would I have in place, and how would I kind of go about designing a study to to observe and see the effectiveness of the intervention that I have in place. I know it sounds tedious, but that's the best way to improve kind of using these kind of tools and methods. Now, last thing we really have to talk about, we talked a lot about quantitative methods, right? A lot of the stuff we talked about today is about taking information based on a variable and how it's associated with another variable, right? That's the easiest way to look at an association. However, if we go back a couple of slides, we also talked about kind of a realistic approach to things, right? We do miss some context. And so there is a spot for qualitative methods to kind of sneak in, right? Maybe in terms of my long-term care example, I'm seeing that my scores aren't going up too much. And then I have a qualitative piece where I'm actually sitting down with PSWs and frontline nurses and asking them about hand hygiene, asking them about what can be improved. And after that, I find out that maybe a superior has been rushing them to get a certain amount of care done in a certain amount of time. Well, it doesn't matter how much education I put out because they're feeling pressure from a superior to altogether skip hand hygiene, right? I wouldn't get that piece if I didn't have a qualitative piece to my methodology. In that kind of sense, it's really important to use a mixed methodology when afforded the opportunity, all right? Qualitative methods do take more time and resources, but they really portray the other half of info that you need. They give you that kind of personal experience as opposed to just numbers. Keep this in mind when designing kind of how you're evaluating your interventions, because while you can get a majority of your stuff done through quantitative means, like I said, the qualitative kind of aspect to it is really going to give you the full picture when you use both in conjunction. As usual, the slide template comes from Slides Go, so there you have it. Lastly, make sure you do the weekly quizzes. Weekly quizzes close on Friday. After Friday, you start incurring the penalty of 10%, then 20, then 30, and then 0. All right, so make sure you get that done. If you have any kind of technical issues, please let me know beforehand, and we'll try and sort that out. If you do message me at like 7:55 and the quiz is due at 7:59, you run the risk of me not seeing that email and being able to help, okay? Just make sure you try that quiz a little bit early. Don't leave it to the last minute. And other than that, we'll talk next week.